Our next speaker is someone that has been a rising star in GOGS. She has been nationally on a lot of committees, but locally in our state, we are seeing her, and we're going to see lots more of her. So Dr. Bunja Rungruang is from MCG. She is a professor and section chief of GYN oncology at the Medical College of Georgia at Augusta University. She also serves as a fellowship director for GYN oncology. She holds a Bachelor of Science in Neuroscience and Behavioral Biology from Emory and a Doctor of Medicine from the University of Alabama. She completed her OBGyn residency and GYN onc fellowship at McGee Women's Hospital at the University of Pittsburgh Medical Center. She's an award-winning educator and an active contributor to the community, and she has been our secretary-treasurer for 2 years, and now she is president-elect of the society. So please welcome Dr. Rungruang.
All right. Thank you all. Thanks to the program committee, Dr. Kuntz, Dr. Green, for allowing me to speak today, and thank you, Dr. Bonk, for that introduction. I have no financial disclosures. I do, however, apologize in advance to anyone who has heard this at a grand rounds before. When they asked me to give it again, I was honored to do so. Hopefully, they got enough out of it the first time to think that it was worthwhile to hear again. These are our learning objectives for today. We will review BRCA and Lynch hereditary cancer syndromes, and then discuss some of the less common ones that are starting to become more prevalent, and you may come across those in your patient populations. We're going to review genetic testing guidelines and define what variants of uncertain significance are, and discuss screening guidelines for patients with hereditary cancer syndromes. And then we'll also briefly touch on the use of HRT in this patient population. We had a wonderful menopause lecture yesterday, but this patient population is a little bit special, so we'll talk about the nuances of that. For our outline today, we're going to start with the risk assessment for genetic testing. So let's start by discussing why this should be important to even the non-GYN oncologist in the room. The ACOG Committee Opinion number 793 on hereditary cancer risk syndromes states that risk assessment really should be performed by OBGYNs, and that should be updated regularly when you're seeing these women each year for their annual exam. And if the assessment suggests an increased risk of cancer, then you should refer them for to cancer genetics for evaluation and consideration of testing. So it's really important to update the family history at every visit, and the things that you should be focusing on are, do they have any first or second degree relatives on each side of the family that had cancer, and if so, what was the age at diagnosis and the cancer type, and is there any Ashkenazi Jewish heritage within the family? Every year, when I'm updating this on a regular basis, or at each visit when I'm seeing a patient, if I'm not seeing them regularly during their chemotherapy time, I ask them, any recent family get-togethers? Did you have a family reunion, or at the holidays, anyone has a recent cancer diagnosis that you heard about that popped up? And sometimes that'll jog their memory to remind them to tell me about something that came up. So what are some red flags you should be looking for in that family history? It should include a cancer diagnosis at a young age, particularly below the age of 50 for breast, ovarian, and colon cancers. If there are several different types of cancer within the same person, or an unusual presentation of a specific type of cancer. So, for example, male breast cancer would be a definite red flag. The presence of a benign condition that's known to be associated with a genetic predisposition, like a hamartoma that's associated with Cowden syndrome, or the occurrence of certain types of cancers with a high probability of a hereditary cancer syndrome. And so that would include things like triple-negative breast cancer. If that occurs below the age of 60, those patients have a 30% probability of having a genetic predisposition. Some patients, if they were diagnosed a while back and you're catching them for the first time, they may or may not remember what their receptor status was. So sometimes I'll ask, or if they have a family member who had it, I'll ask, did they go on a pill for several years afterwards? Or how long did they get IV treatment? Because that can give you an idea if they were HER2 positive and got trastuzumab for a year afterwards. They may or may not know that information, but sometimes you can gather a little bit that way. Similarly, a family history of ovarian cancer or mismatch repair deficient colon or uterine cancer would also be a red flag for a potential genetic predisposition, in which case, if you find any of these things, these patients should be referred to a cancer genetic specialist for further evaluation and management. So now let's shift to the genetic testing guidelines and how to interpret those potential results. When I was in residency and fellowship, honestly, most patients were not getting tested. It was very expensive. It wasn't covered by most insurance companies. And just as I finished fellowship, 2 events happened around the same time that really changed the landscape of this and really changed how I managed these patients as I transitioned into practice. The first was the disclosure of the BRCA1 mutation by Angelina Jolie. And that really increased public awareness as well as public demand for testing. And then the second thing was the Supreme Court decision to not allow for gene patenting, which then helped to make the BRCA testing that was so expensive at the time really become much more affordable. And so because of this, incentives quickly shifted towards panels of increasing numbers of genes at decreasing prices. And so because the testing costs have fallen so greatly, insurers nowadays very rarely object to multi-gene panel tests as a means of diagnosing the recognized hereditary cancers in patients that meet the guidelines. However, most payers will not cover more than one genetic test. So if you're seeing someone and you only test them for BRCA1 and 2, that's really a disservice to them because there are so many other things that they're at risk for as well potentially, and a multi-gene panel test would pick that up. The benefits to multi-gene panel testing is that they're cheaper, they're faster, they're more efficient for diagnosis. They may identify mutations within a pedigree that would otherwise not be suggested. I've got a family that I follow with Cowden syndrome. We'll talk about that in a minute. It's a less common one. You may not be as familiar with it, but ovarian cancer doesn't fall into that spectrum. But the mother in that family had ovarian cancer, was genetically tested, as is indicated for all ovarian cancer patients, was found to have Cowden syndrome, and I now manage her daughter, who doesn't have an ovarian cancer risk technically, but she has other risks that I need to manage because of that. The drawback to multi-gene panel testing is that the results can sometimes be complicated to understand. So let's talk more about those. So looking at panel testing, there are 3 levels of uncertainty that complicate the results that you get about the mutations in the less widely studied genes, the ones we're just starting to discover more about. The first of those is the magnitude of the cancer risk or the penetrance. The second is the anatomical and age-specific scope of a given cancer risk. And then third is the clinical relevance of these missense variants in genes for which we really haven't adequately defined the spectrum of normalcy. And these variants of uncertain significance increase infrequently with the higher number of genes that we're putting into these multi-gene panel tests. Most of them have like 70 genes that they're testing for now. And so if you get a variant of uncertain significance and you're not providing skilled genetic testing or skilled genetic counseling afterwards, can really cause a lot of anxiety and maybe some unwarranted interventions. So when I have a patient, when I get their test results and they have a variant of uncertain significance, I counsel them that they're not currently at a known risk of increased cancer based off of that particular VUS, but it does go into a database from these genetic testing companies. And if it does later get reclassified as a pathogenic variant, they will be notified of that. And then if they get that notification, they should let me know as well. I keep the list of, in their notes, I keep the list of their genetic testing as well as any variants so that I can keep track of those if something does become a pathogenic mutation. But if they do have a variant of uncertain significance, not anything pathogenic, but they have a very strong family history, I oftentimes will counsel them on the risks and benefits of surveillance to decide together with shared decision-making if it would be worthwhile for them. So as outlined in the ACOG Committee Opinion number 727, cascade testing refers to the performance of genetic counseling and testing in blood relatives who have been defined with certain, with specific genetic mutations. So for example, if you have a patient that you identify with BRCA and a specific variant of that, then you can go ahead and test the rest of the family members that decide to get tested for that specific mutation. It's much more cost-effective that way. If you have a patient that's concerned about future insurance implications, if a positive result is found, they should be informed that the Genetic Information Non-Discrimination Act, or GINA, is a federal law that protects against discrimination from employers and health insurers based on genetic information. This, however, does not include or does not apply to disability or life insurance. So when I'm seeing a patient that has a known genetic predisposition and I'm talking to them about how they're going to tell their family members about this, I always make sure that I tell them if their family members do not already have disability or life insurance and that's something they would like to pursue, they should look into that prior to undergoing the genetic testing. They could undergo genetic counseling, but once they get that genetic test and get a positive result, it may impact their ability to get those types of insurances later on. So next in our outline, when I think about or when I teach about genetic cancer risks, I really think about it in two ways. The first is all the associated cancer risks by a disease site. So for example, all the genes that are associated with a breast cancer risk. So we'll talk about that first. And then the second way I think about it is consolidating all of those specific screening guidelines based on the hereditary cancer syndrome. And I keep a checklist in all of my patient notes for what screening they need to do. So we'll talk about that second. So this figure is a very, very busy figure, but I put it in here because it illustrates the gene mutations that are grouped by their association with a particular cancer disease site. So each of the colors represents a cancer disease site. Each of the little spokes along the wheel looks kind of like a pregnancy wheel. I don't do that anymore, but that's what I remember it looking like. You probably all have apps for that now. Are all the mutations. And then all the arrows around the outside are patients with mutations that I take care of. And so it really shows you how it can span across so many different disease sites in these patients. And so you really have to be on track with what they're at risk for. This table is from the ACOG Practice Bulletin number 182 and shows the multiple genetic mutations associated with hereditary breast and ovarian cancer syndromes. So in pink here, you can see the ones that are associated with the risk of breast cancer. They have not updated this yet in the practice bulletin, but in the most recent NCCN guidelines, RAD51C and D that you see there towards the bottom of the table are also associated with an increased breast cancer risk. The teal arrows denote the mutations associated with ovarian cancer. And then it's a little faint up there, hopefully you can see it. The two stars there are the ones that are associated with uterine cancer. So let's start with the ones that are specifically related to breast cancer. So as an OBGYN, you're most likely to see patients with a family history of breast cancer when you're doing your routine well-woman care, given the prevalence of breast cancer in the United States. And of the genes responsible for hereditary breast cancer, there are some that are highly penetrant and more likely to result in cancer, whereas others are moderately penetrant. And that level of penetrance, which determines the risk of breast cancer, also dictates the screening and management guidelines and recommendations. So we'll go through those in just a moment. Let's switch here. There we go. So I really like this figure. I use this a lot when I'm teaching my fellows about the homologous recombination pathway for some of the drugs that we use, but I also really like it when I'm teaching about cancer genetics. It shows all of the genes that are involved in this homologous recombination pathway that are involved in ovarian cancer risk there on the left, and then for breast cancer risk on the right. And you see BRCA1 and 2 are central to this, but there are so many other mutations that we've already talked about today that you can see are in this spectrum, and now I think it makes it a little bit more sense why we talk about all of these other mutations as well. So the ones in maroon are the highest risk. Red is the next highest risk at moderate. Orange is a lower risk, and yellow, they're in the diagram, but not at any risk of increased cancers for these types. So we'll break these down further. Again, starting with breast cancer. These are all of the genes listed here that have a high penetrance or a high risk of breast cancer. And so again, that dictates the screening guidelines. And so for breast awareness, that should start at the age of 18 for all of these. They should undergo clinical breast exams every 6 to 12 months starting at age 25. And then BRCA 1 and 2, as we all know, confers the highest risk. And so in that patient population, they should undergo annual breast MRI between the ages of 25 to 29. For everything else on this list, screening starts at age 30, and that should be an annual MRI alternating with mammogram. The one exception to this is P10 or Cowden syndrome. Onset's just a little bit later, so you can start at 35. And then this should go until the age of 75 or be individualized. Hopefully, they're getting counseled regarding risk-reducing surgery because of the high absolute risk of breast cancer in this patient population. The recommendation is for mastectomy for risk-reducing surgery, and so they should all be counseled on that and then be referred to a breast surgeon for that management. These are the genes that are moderately penetrant in this group. The risk of breast cancer is just slightly lower, and the onset is just slightly later, and so again, that dictates the recommendations. So for most of the ones on this list, the screening should start at the age of 40 with annual mammogram alternating with MRI. The two exceptions to this are ATM and CHEK2. Those have an earlier onset, and so you can consider breast MRI annually starting between the ages of 30 to 35. Because of the moderately high risk, the absolute risk is still not high enough in these patient populations yet to recommend risk-reducing mastectomy. So I send these patients to a breast surgeon for that counseling, and oftentimes they'll individualize it based on the family history with shared decision-making on the risks and benefits for the patient. So let's shift to ovarian cancer. For the genes listed here, the risk of ovarian cancer is elevated above the general population. So screening recommendations for most of these, almost all of these, include a risk-reducing salpingo-oophorectomy based on the average age at presentation for a particular genetic predisposition. We all know that the highest risk is with BRCA1, and so that's also the earliest onset, and so the earliest recommendations for surgery, which is between the ages of 35 to 40. Our next highest risk is for BRCA2 and slightly later onset, and so the surgery should be performed for risk reduction between the ages of 40 to 45. This next cluster, BRIP1, PALB2, RAD51C and D, they still have an elevated risk of ovarian cancer, but it's a slightly lower risk and a later onset. So all of these can be considered for risk-reducing surgery between the ages of 45 to 50. This next section is for Lynch syndrome. And so there are 4 genes involved in Lynch syndrome. Depending on which one they have that puts them in that genetic cancer predisposition depends on what the recommendations are. So the highest risk is with MLH1 and MSH2. The time and onset of presentation is variable across these as well, but in general for MLH1 and MSH2, those patients are at an increased risk and should undergo risk-reducing surgery. The risk is lower with MSH6 and I think shared decision-making in that patient population for whether or not oophorectomy is performed. In PMS2, actually, they have a very low risk. It's just barely above general population. And so technically the guidelines say with a PMS2 mutation, you do not need to remove the ovaries. We'll talk about Lynch again in a few minutes when we talk about uterine cancer risk, and honestly, most of my patients with Lynch oftentimes will just go ahead and do the total hysterectomy. The last one on this list is ATM. This mutation is just slightly elevated above the general population. So just because it's very slightly elevated, there's insufficient evidence at this time to recommend risk-reducing surgery. So oftentimes it's based on family history. Honestly, all of the ATM patients I've ever seen, it's always been in the context of a breast cancer that they've already had that identified their mutation, and they're seeing me for oophorectomy in the setting of hormone receptor positive breast cancer to lower their risk. Considering your risk-reducing surgery options, we all know that the gold standard is for salpingo-oophorectomy, and we're familiar with how that procedure is done for risk reduction. I think the real discussion with the patient is whether or not to include a hysterectomy with it. And I really discuss this with each patient on an individual basis and really go through the pros and cons of one option versus the other. It's about 50-50 for me and my patient population of whether or not they decide to get just the oophorectomy versus the total hysterectomy. Generally, the uterus and cervix are not at risk of cancer in the same way the fallopian tubes and ovaries are in this patient population, although some data have suggested a slight increased risk of serous endometrial cancer in the BRCA1 population. And since serous cancers are more difficult to detect early, some women may go ahead and choose to have hysterectomy at the same time of their risk-reducing salpingo-oophorectomy, just to really maximize their GYN risk reduction. Another potential advantage to hysterectomy in this patient population is to facilitate postoperative hormonal therapy, allowing for the use of estrogen only, or to decrease the uterine risk in women who go on to tamoxifen therapy or who are currently on tamoxifen therapy for their breast cancer risk reduction or for their breast cancer treatment if that's when their genetic predisposition was found. And there may be benign GYN conditions such as fibroids or abnormal paps, et cetera, that drive the decision for hysterectomy as well. Conversely, hysterectomy increases the surgical time, the recovery time, and the postoperative restrictions, and the potential for surgical complications. Some patients may ask about what other alternative surgical options are available. We all know that ACOG and SGO endorse opportunistic salpingectomy in the general patient population for risk reduction, but again, this does not apply to this special population with a genetic predisposition to cancer. So one option currently under investigation is salpingectomy with delayed oophorectomy, or SDO. For this, the salpingectomy is performed, and then oophorectomy is delayed until a later time, but still within the recommended age range for that genetic predisposition. The potential barriers to this are that it does require 2 separate surgeries with double the perioperative risk. There's uncertain compliance if the patient will return for their delayed oophorectomy, and the need for prolonged follow-up. You have to keep up with their screening until they do undergo their oophorectomy eventually. Also, it does not confer the 50% breast cancer reduction as you would get with the risk-reducing salpingo-oophorectomy, since the ovaries are still intact. However, in the preliminary studies for this, the majority of women do find this approach to be acceptable. In the initial pilot study, women who underwent SDO had no intraoperative complications, were satisfied with their procedure choice, and had decreased cancer worry and anxiety postoperatively. So based on these promising results, several prospective observational trials are currently being conducted to further evaluate the impact of SDO over risk-reducing salpingo-oophorectomy in terms of efficacy in preventing the development of cancer, as well as on the quality of life. There are 2 trials in the U.S., the WISP study and the fourth one there, the SORAC study. We'll talk about that one more in just a moment. In the Netherlands, they have the TUBA study and then the Protector trial in the UK. So studies have focused on the safety and quality of life impact, mostly with the interval salpingectomy option with the delayed oophorectomy. What we don't know about is what is the benefit to salpingectomy only, and the maximum and still theoretical benefit of that will not be fully realized until the data show that oophorectomy can really be safely delayed until the time of menopause or after that time, or not do it at all. The 4th NRG study that I mentioned in the last table, the SORAC study, they will include some patients that do opt to defer oophorectomy until after the recommended age towards menopause, and maybe will provide some insight into the benefit of a salpingectomy alone strategy. But you have to remember that this patient population that we're pulling from is really small, and then the ones within that patient population that decide not to get an oophorectomy is going to be even smaller. So mature data for this is years away, decades away, if we even get enough power to answer this question. So really at this time, there's no data to support salpingectomy only in this high-risk patient population, and the salpingectomy with delayed oophorectomy really should only be offered in the setting of a clinical trial, so really steer them towards the risk-reducing salpingo-oophorectomy. We know the recommended risk management options in these high-risk mutation carriers is the surgery that we've talked about, but for those who don't elect to do so or are younger than the recommended age for surgery, what screening options exist for these patients? And the NCCN guidelines that were outlined prior to 2016, the recommendation was for screening with transvaginal ultrasound and with CA-125. This was based on this UK collaborative trial of ovarian cancer screening, and their preliminary results were published in 2009. They compared transvaginal ultrasound and CA-125 with ultrasound alone versus observation, and found that multimodality screening was more effective at detecting early-stage cancer. However, when the NCCN guidelines were updated, which happens about every 4 years, they were updated in 2020, this recommendation was changed, and that was due to 3 studies that were published since the 2016 guidelines were set. The first was the follow-up long-term study, long-term data from this study, which was published in 2016. They had a median of 11 years of follow-up at that time, and they actually did not show a significant mortality risk reduction in this group. The second study was the UK Familial Ovarian Cancer Screening Study that included almost 4,400 women with an estimated lifetime risk of cancer of 10% or more. They underwent screening with CA-125 tests every 4 months and used a ROCA algorithm to interpret those results. And this was paired with annual transvaginal ultrasound or sooner if, within 2 months if the ROCA score was elevated. ROCA is the risk of ovarian cancer algorithm. It's a statistical method that calculates a woman's risk of ovarian cancer that factors in a combination of age, menopause status, and the CA-125 level. So in this study, 13 patients were diagnosed with ovarian cancer, and 5 out of those were early stage. The sensitivity was good at 94.7%, the positive predictive value was 10.8%, and the negative predictive value was 100% for detecting ovarian cancer within 1 year. And then finally, in the last study by Skates et al., they included almost 3,700 women who were at increased risk of familial or genetic risk of ovarian cancer. And they also used a ROCA-based algorithm. They used CA-125 every 3 months and annual transvaginal ultrasound or sooner based on abnormal CA-125 results. And they found 6 incidental ovarian cancers, and half of those were early stage. So really the results of these studies suggest a potential stage shift to earlier cancer detection when a ROCA-based algorithm is used in these high-risk women, but it's still unknown if this impacts survival and hasn't really been shown to do so, so that's why the NCCN guidelines were changed. However, they do say that you can consider at the clinician's discretion starting at age 30 to 35 years, and so in my practice, I discuss the risks and benefits of screening, taking into account the family history, and I really make a shared decision with the patient. Honestly, everyone who comes to see me decides to get the screening because they're scared to death they're having to see me in the first place. So let's move on to the uterine cancer genes. For Lynch and Cowden syndrome, they have an increased risk of endometrial cancer, as we mentioned earlier. For Lynch syndrome, just like with ovarian cancer, the risk and onset really depends on which of the Lynch genes is involved. The highest risk and earlier onset are with MLH1 and MSH2, just like with ovarian cancer, so the first 2 are the worst ones for both. The data for Cowden syndrome is much more limited. It's a much less common genetic predisposition. And the sources, for the most part, report that the onset's in the 30 to 40 range, but some say up to 50. And then there's case reports where it's in the 20s as well. It's kind of all over the place. So in general, for these, in terms of the uterine and the endometrial cancer screening, it should start around age 35. The patient should be given education about irregular bleeding. They should maintain a menstrual calendar to identify any abnormalities in bleeding. And then they should know to report that immediately, and that should prompt an endometrial biopsy. Endometrial biopsy with routine and routine screening in the absence of symptoms has not really been shown to have a proven benefit. But we all know that endometrial biopsy is highly sensitive and specific as a diagnostic procedure. And screening with endometrial biopsy can be considered every 1 to 2 years and is actually recommended by the ACOG practice bulletin for Lynch syndrome. transvaginal ultrasound is not sufficiently sensitive or specific. It can be used as a screening tool at the clinician's discretion, but you really should not use that in a premenopausal patient population. And then risk-reducing hysterectomy is indicated for Lynch and for Cowden syndrome. Oophorectomy, it's dependent upon which mutation it is for Lynch syndrome, but again, most of my patients all go for the total hysterectomy. But for Cowden syndrome, they're not at an increased risk of ovarian cancer, so it's really not indicated for oophorectomy in that patient population. Prior to risk-reducing surgery, depending on where they're at with their childbearing, I usually will recommend a leave-in adjustable IUD for its protective effect on the endometrium. All right, so we're going to consolidate all that together now, and I'll show you what my checklists look like for my patient notes as I'm keeping track of these patients as I'm seeing them on a regular basis. I want to preface this next section by reminding you that cancer screening in high-risk patients is really a collaborative team effort. I personally never ordered genetic testing myself. I instead always refer to our cancer genetics screening program, which includes a physician with a special focus in cancer genetics and a genetic counselor. I have that luxury. I understand some people in some places may not have that luxury. But for me, the counseling going into the testing, choosing the correct test, discussing the results takes quite a bit of time. They're also very good at tracking down the rest of the family members and performing that cascade testing. So that's why I utilize them for this. So let's start with the one we're most familiar with. That's the BRCA mutations. The risk estimates for cancers with BRCA 1 and 2 vary depending on the source. And so I pulled this from UpToDate, which sourced the data from the National Cancer Institute, or NCI, DevCan database earlier this year. We all know that the lifetime risk for breast cancer is higher in BRCA1 than it is in BRCA2, particularly in those diagnosed at a younger age, below the age of 50. And the risk of a second breast cancer also appears to be higher in the short term with BRCA1 patients. But keep in mind that both mutation groups do appear to have a higher risk over time, up to a 63% risk of a contralateral breast cancer over the next 25 years, so a really long time out post-diagnosis. So in the patients that don't undergo risk-reducing surgery, they really need close monitoring for that other side. We also know that the incidence of ovarian cancer is higher in BRCA1 than it is in BRCA2, particularly in those diagnosed prior to the age of 50. Conversely, the risks of male breast, prostate, and pancreatic cancers are higher with BRCA2, and they also carry an elevated risk for ocular melanoma. So this is what my checklist looks like for BRCA patients. It's much more straightforward, you're going to see, than the other ones that I follow. For their breast cancer, I always make sure that they're seeing a breast surgeon for surveillance and surgery options. Even if they're resistant to surgery, I tell them they've got to go see the breast surgeon so that they've got someone who's closely monitoring their screening imaging as they're continuing to get that, in case little things pop up in that imaging. For their ovarian cancer, we've talked about the risk-reducing surgery and the timing of that. And then pancreatic cancer also falls into their spectrum. Again, it's higher for BRCA2 than BRCA1, but if any of these patients have a first or second degree family member on the same side of the family with pancreatic cancer, then they should undergo pancreatic screening starting at the age of 50. I used to refer these to GI for that management, but at MCG we now have a pancreatic screening clinic that's multidisciplinary, and they've been great about managing the risk for these patients, so I have a lot of patients that go to that clinic for their screening. So let's move to Cowden syndrome. You may not see this that often, but I think as our breast cancer patients are getting tested more frequently for genetic testing, that's where a lot of these are getting picked up. They have a lot more in terms of their cancer risk, so multidisciplinary approach is really important in these patients. They should be seeing a breast specialist, and honestly, like I said, the majority of the patients I see, like 90% of the Cowden patients I see, have already had a breast cancer, so that's how it got found in the first place, and they're following with someone already regularly for that. You should be managing their endometrial risk, like we already discussed. And they should be seeing GI for a colonoscopy every 5 years, starting at the age of 35. So the screening for this patient population starts very young. Renal ultrasound should be starting at the age of 40, and then every 1 to 2 years after that. Melanoma, for their melanoma risk, they need annual dermatology exams. This patient population also has hamartomas, like I talked about way back at the beginning of this talk. And so it's probably a good idea for them to follow a dermatology anyway. And then they're at risk of thyroid cancer, and that onset can be quite early in this, with this genetic predisposition. So they should get annual thyroid ultrasound screening starting at the age of 18. So again, that's a lot for these patients. I follow them yearly for the most part and keep this checklist just to remind them that they need to do these things to make sure that they're being done. But now that we have a pretty robust cancer screening clinic, they've been pretty good about following these patients, but I tell them they need some cruise director always making sure that they're getting all of their screening done. Moving on to Lynch syndrome, this one also requires a multidisciplinary effort. The bulk of their risks are GI related, so that's going to be your biggest partner for these patients. They need a colonoscopy every 1 to 2 years and an EGD every other time. You should be managing their ovarian and endometrial risk like we already discussed. And I check an annual urinalysis in this patient population when I see them for cytology. It was previously a recommendation, like a hard recommendation. Now it's something you can consider. It's easy enough to check, and a lot of my patients do have a kidney cancer somewhere in their family history. Pancreatic screening for this group can also start at the age of 50 based on family history, and again, they're already seeing GI, so GI may just want to go ahead and manage those risks with them, or you can send them to the pancreatic screening clinic if you have something like that at your institution or in your vicinity. So it's a lot to remember for all of this, right? And so when I'm seeing patients with a genetic predisposition in the office, oftentimes they've Googled a lot of things before they've come to see me. These patients tend to be very well informed, and so it's free to sign up on the NCCN website, the National Comprehensive Cancer Network, for online access, and they have these great genetic guideline tables like this within that. They've got the most common ones, and then some that you may not see in practice, but I see because I get all of the patients from that genetic screening clinic. And so it's really a great quick reference. If I have a really well-informed patient that's really looked up a lot of things online, I will sometimes print the section pertinent to them, the portion of the table, highlight what's most important so that they've got that additional information. So I know they've gotten it from a reliable source and not from TikTok, as we talked about yesterday. And so finally, let's end with a brief discussion of the HRT use in this patient population with increased cancer risks. So again, yesterday we discussed the results of the Women's Health Initiative study and the Nurses' Health study, and we all know how those raise concerns about hormone replacement therapy. What we have to remember is that patients in this study underwent spontaneous menopause in their 50s and then took HRT in their 60s. That is a completely different patient population than what we're talking about here, where oftentimes we're making decisions and performing surgeries on patients in their 30s to 40s, well before they would have normally gone into menopause. And so the conclusions from the WHI really are not applicable to this patient population. So with that in mind, in women who have not had a hormone receptor positive breast cancer themselves, no study has shown an increased risk of breast cancer with hormone therapy in women who have undergone a risk-reducing salpingo-oophorectomy prior to menopause in this genetic predisposed population. In addition, one study conducted in patients with BRCA 1 and 2 mutations demonstrated that short-term use of hormone therapy did not negate the protective effect of the risk-reducing salpingo-oophorectomy on the risk of a subsequent breast cancer, and the majority of these patients were receiving estrogen alone, not combined estrogen-progesterone therapy. So it may be worthwhile considering removing the uterus at the time of risk-reducing salpingo-oophorectomy to facilitate HRT use with estrogen only, or a levonorgestrel IUD can be considered again if it's retained. Even in a woman who does not want to take systemic hormone therapy, and again, I really have to do a lot of education with these patients. They've read a lot about it. They're scared to death about anything that could even remotely increase their risks of cancer now that they know that they've got this genetic predisposition. I always counsel them that local estrogen treatment in the vagina can help with dyspareunia and vaginal dryness and urogenital symptoms, and it has not been shown to increase the risk for breast cancer since it's largely limited to the local tissues. As we heard in the menopause talk yesterday, though, such treatment does not help with other menopausal effects, such as heart disease, osteoporosis, and hot flashes. So oftentimes, if I can at least convince them for vaginal estrogen, then I'll revisit the topic of HRT again after that, after I've gotten my foot in the door. HRT, as we know, is contraindicated in women with a personal history of hormone receptor positive breast cancer in this patient population and other comorbid contraindications to HRT otherwise. All right, I gave you a lot of information today. I'm very detail oriented, but hopefully you've got a good resource now if you encounter these patients. So I'm just going to do a few summary slides and then we'll see what questions I've left you with. So risk assessment should be performed by OBGYNs and should be updated regularly. Please, please, please do this. You're the ones who oftentimes will catch these and then get them the help they need before they need to see me for a cancer reason. If assessment suggests an increased risk, refer to a specialist in cancer genetics. Multi-gene panel testing should be performed, followed by cascade testing of the family members, ideally to prevent cancers in multiple generations. I've got several 3-generation families that I follow at this time. With these genetic predispositions. Breast cancer screening and risk-reducing surgery recommendations are based on gene penetrance, as we discussed. Patients at a high risk of ovarian cancer should undergo risk-reducing salpingo-oophorectomy plus or minus hysterectomy at the age intervals determined by their penetrance, but not just a salpingectomy. Transvaginal ultrasound and CA-125 screening have not been shown to decrease mortality and are not recommended technically by NCCN, but can be considered at the age of 30 to 35. Cowden and Lynch syndrome increase the uterine cancer risk and require the endometrial screening and risk-reducing hysterectomy. And finally, hereditary cancer syndromes have specific screening criteria based on their penetrance, the disease sites affected, and the age of cancer onset. These patients really require, like I call it, a cruise director to make sure that they're getting to all the people that they need and not forgetting what they need to do because it's a lot for them. HRT can be considered in these patients if they do not have a history of hormone receptor positive breast cancer. Short-term use does not negate the protective effects of the risk-reducing salpingo-oophorectomy on the risk of subsequent breast cancer if they have not undergone their risk-reducing mastectomies yet or have elected not to do so. Hopefully, they don't end up with they're at high risk of cancer regardless if they have not elected to do so. And then vaginal estrogen has not been shown to increase the risk of breast cancer since it's local. So I'll end with showing you some genetics at work in real life. This is me on the left in kindergarten and my daughter Lola at the same age. Right? And then you can see it's persisted over time. She's 15 now. I call her my mini-me, but she's actually a little taller than me, so she's not really my mini-me anymore, but looks just like me. And again, I would like to thank the program committee for inviting me to speak today. I thank you all for your attention, and sorry if you've already heard this talk before at Grand Rounds, and would be happy to answer any questions that you have.
Thank you very much for the excellent presentation. And I felt that it's very smart you recommended that you do not do genetic testing yourself because there's a lot of medical liability if you have found one of the BRCA1, BRCA2, Lynch or Cowden positive, and then you do recommend the patient to have certain thing and they do not follow with that. So do you have any particular thing that the general gynecologist can do just a limited for thing without increasing the medical liability, legal liability?
Yeah, that's a great question. So when I get referred these patients after they've had their diagnosis of their genetic predisposition, I put in all of my notes, like I said, what their checklist is for follow-up, and I send that back to the referring OBGYN, or if they, oftentimes they're referred to me by the genetic screening clinic. And so I find out who either their primary care provider is or who their OBGYN is, and I send that information back out to them. I oftentimes will communicate with that with the referring provider or the PCP or primary OBGYN directly and ask them what their comfort level is in managing any of these risks. I have some people where if they're getting every 6 months surveillance testing before they're ready for their surgery, some of them will agree to do it. Some of them say, nope, that's all you. And so I'm happy to do that, and I'll keep the patients on target for that. And then whenever these patients are ready to undergo their risk-reducing surgery, I also discuss that with the OBGYN to see what their comfort level is, because remember, you've got to take a good segment of that IP ligament, and if that's not where they're used to being, and if they're not comfortable getting enough of that to assure that they've gotten all of the ovarian rest tissue, then I tell them that I'm happy to do that surgery. The majority of people will just refer them back to us. Once they're already plugged in with us, we're happy to keep seeing them. But that's what I try to do to absorb a lot of that burden from the providers in the community if they're not comfortable with that from a medical legal standpoint.
Thank you very much. I appreciate it.
Yes.
I'm aware that there has been a recent acknowledgement of a significant lack of racial diversity included in the previous predictive DNA research, particularly lacking from African Americans' ancestral DNA. Mm-hmm. And I would like for you to comment on what our concern should be regarding the validity or the penetrance or predictability for these results for this population. Should we say, okay, you're positive, it's great, but there is a potential increase in a false negative result for you, or any comment regarding it?
Mm-hmm. That's a great question. And so, for the genetic testing, once the patients are undergoing genetic testing and they have a positive result, the way I counsel them is that this positive result has been associated with an increased cancer risks. The cancer risks are a wide range, but we think it would fall somewhere in this range. But for an individual person and an individual family, that may differ. So based on the whole, this is the general recommendation for how this is managed. I also take a 3-level family history on both sides when I see these patients, though, and really factor that into a family history. I have several patients, African American patients that I follow where their genetic predispositions do not match the cancers that fall into their family. And so I'm a big advocate of multi-gene panel testing for that reason, because oftentimes it will capture things that I would not normally see. For example, I have a family, I followed 3 generations of this one family with a BRCA2 mutation. The first patient was a patient with a serous endometrial cancer, African American. It came up on her molecular testing that there may be a BRCA2 mutation, which would be unusual with a serous endometrial cancer. We talked about it's maybe BRCA1, but not BRCA2. I tested her, she was positive. I tested her sisters, they were all positive. The kids, all positive. The grandkids, all but one are positive. So I follow multiple people in that family. So I tell them, I tell anyone that I see that we don't know exactly for you as an individual. This is the best information we have so far, and based off of a family history is really how I individualize that for them, because it will look different in different families.
Right, and the good news that I'm aware of is that Morehouse School of Medicine was recently awarded a significant grant, and the geneticists to work on getting pooled DNA from Western Africa, et cetera, so that the predictability is more reliable.
Yeah, and we've been using that grant, the Paceline grant, to try to get more of that information, because we have a very diverse patient population where we can easily get sampling. Our patients have been really great about agreeing to participate in that so that we can hopefully get that information. Thanks for that question.
Hey, last one? Okay. Dr. Rungruang, thank you for that talk, and I appreciate you adding on the HRT at the end and what we should do in these special populations. One thing I do tell patients when we're going to do vaginal estrogen for genitourinary syndrome of menopause is you're going to go home and you're going to read that packet insert, and it's going to tell you that it causes breast cancer. Yes. But that's because the FDA has put a blanket, warning on all hormone therapy regardless of evidence. So I think going ahead and setting that expectation ahead of time is important. My question to you is, as generalists, when we're managing this, condition, do we need to contact the oncologist, have a discussion with them, sort of get permission from them? What's our best approach?
So if they do not already have a breast cancer, then no. If they already have a breast cancer, you actually may be the one that needs to educate the medical oncologist about that. I'll oftentimes have to pop down the hall in the cancer center and be like, hey, this patient's telling me that they can't do this, but let me just tell you about what these studies have shown more recently and what the data is for this. And oftentimes when I have that discussion with them, they'll give in a little bit and say, okay, at least vaginal estrogen, because I'm like, they're really miserable. And if it were you, I think you might reconsider. Yeah. All right. Thank you all so much.